We have the option of RPs with docetaxel and some of the PARP inhibitors. Now, if the disease was to progress, in that scenario, we have Pluvicto, if a PSMA
Hmm.
positive disease is what we are dealing with, or Cabazitaxel, and we should not forget with bone-only disease, the utilization of radium-223. Alan,
Yep.
can you touch on what's your approach here?
Yep. So, as you say, we've got a lot of options. When as a medical oncologist, right, when we're thinking about long-term outcomes for our patients, with a prostate cancer patient, of course, I'm always thinking about the entire treatment course, right? How the various drugs interact with each other, not just each individual step,
Right.
right? And if you come out of triplet therapy, you hit mCRPC and it's BRCA2 mutant, PARP would be my default. If it's BRCA wild type, Pluvicto is mostly the default, right?
Yep.
Um, Radium, certainly for bone-only disease. We have various studies showing the sequencing of radium and Pluvicto, and as long as there's enough marrow reserve, it works. We also have the recent Peace 3 data showing you can do Enza plus radium, right? Although none of that was post-Abi or post-ARPI. What do you make of that? That's debatable, right? Cabazitaxel, still tried and true. I use it, every week practically. Compared to Pluvicto, we have the therapy study, which was Cabazi versus Pluvicto head to head. They gave equivalent overall survival. Right? Pluvicto is better for PFS, better for toxicity, but Cabazi is just as good for OS. So if there's a financial barrier or some other barrier, if you don't have access to Pluvicto in your community, there is absolutely nothing wrong with Cabazitaxel.
Absolutely. And Alan, just before we close, we're talking about resistant disease, role of carboplatin when you're adding it to either cabazitaxel, where are you using carboplatin?
Yeah, so when we start getting the treatment emergent small cell or neuroendocrine phenotypes, then I'm really looking at platinum doublets. And that's another of the common final pathways for prostate cancer patients. The more successful we get at treating patients through multiple lines of therapy and keeping them alive, the more likely we are to get anaplastic variants of disease, highly aggressive. So in prostate cancer, that often manifests with atypical patterns of metastatic disease. Genomically, you'll see MYC amplification and RB loss. RB comes back to the picture, right? These are the patients that really start acting like small cell. And then I'm really looking at platinum doublets. And if I have a pure small cell, I'm heading down that small cell lung pathway,
Yep.
EP plus checkpoint inhibitor. But
Absolutely.
if you have a mix, components of adeno and components of neuroendocrine, not fully small cell, then I'm thinking, taxane plus carbo, right?
Absolutely.
Because you're really treating both phenotypes. So I use plenty of carbo combinations. If you have that patient where you're sixth line, you've been through everything, and you're thinking, what can I add? That's another place where I bring in the carbo and often get good results.